Good morning to all. I am Dr. Karthik Natarajan, Associate Professor of Cardiology at UN Mehta Institute of Cardiology and Research Center. Today we'll be discussing a topic which is very close to my heart. It's radiation exposure in CATHLAB and measures to prevent it. As an interventionist, it's not only important to perform procedures, but to perform it safely and to decrease the amount of radiation exposure that we have in the CATHLAB, both for the patient as well as the operator. So what is ionizing radiation? Ionizing radiation is radiation that carries enough energy to remove an electron from an atom or molecule. An exposure to ionizing radiation causes damage to living tissue and can result in cell damage and potentially cancer and death. So we'll be discussing under the various headings of X-ray production, something about the physics of image formation, the dosing vocabulary, radiation risks to the patient and operator, radiation protection, radiation in pregnancy, and the take-home message. So this is how an X-ray is produced. Basically, the X-ray tube converts electrical energy into X-rays. Its key components are tungsten filament, which is housed in a focusing cup, and an anode disc, which rotates at a speed of 10,000 revolutions per minute. And electrons are emitted from the selected filament by thermionic emission. And the number of emitted electrons and thereby the tube current is controlled by adjusting the filament temperature. These electrons are accelerated towards the anode by the electric field, which is supplied by the generator. And X-rays are produced when the electron hits the anode. Now the image formation. So image contrast. The images are formed whenever you have photons of intermediate energies. The high energy photons will strongly penetrate both the tissue and iodine, and this reduces the contrast. And low energy photons are absorbed by the patient's tissues. They contribute to risk but not to image formation. And these require permanent placement of an aluminum filter in the beam to absorb these non-productive photons before they enter the patient and cause damage. So if you look at the figure on the right side, you will see that complete penetration generates the image and the total absorption causes the patient dose. And what is most important is the scatter radiation or scatter interaction, which not only distorts the image but causes patient and staff dose. So images are formed when different structures in the body absorb different amount of radiation from the beam. The contrast agents usually contain iodine, which is a strong absorber of the X-ray photon. Now there is something known as image noise, and this is the radiographic image of a totally uniform object, has random variations in brightness from point to point and over time. And this point to point variation in the brightness is called as image noise. As the X-ray dose increases, the noise decreases. The image sharpness. Now the primary sharpness of an object is decided by the interactions between size of the X-ray's focal spot, position of the object between the X-ray tube and the image receptor, the object's motion, spatial resolution properties of the image receptor. And there is something known as a geometric blur, where you have a loss of sharpness in the X-ray image from large focal spots at high geometric magnification. And for the sharpest imaging, the point of impact of the electron beam on the anode should be as small and as focused as possible, so that the X-ray emission appears to come from a single point focal spot. Now, the X-ray tube usually have two filaments and hence two focal spots. The smaller one is 0.3 to 0.5 millimeters from fluoroscopy, and larger focal spot is 0.8 to 1 millimeter, which accommodates the higher cine images. Now, the concept of a motion blur. Now, the coronary arteries, they are moving objects, so you tend to have a motion blur, and a shorter X-ray pulse will result in less movement blur than the longer pulses. Now, if a small focus is used to reduce the geometric blur, the pulse width may be prolonged to avoid melting the X-ray target. This increases the movement blur. Some fluoroscopes automatically switch the focal spot based on the patient size and the beam geometry. This is a particular feature of the new Philips machine which is available, and the resultant run-to-run changes in vessel sharpness might be clinically confusing if this is not known. So you need to get used to the machine which you are using. Now we come to scattered radiation. Now what is scattered radiation? So scattered radiation is produced when the X-ray beam interacts with the patient or other objects and is redirected rather than absorbed completely. When scattered radiation reaches the image receptor, it reduces the contrast, and it's the primary source of exposure of laboratory staff. So producing an X-ray image, it involves balancing many factors: image contrast, spatial and temporal sharpness, image noise, patient exposure. And improving performance in any of these areas, one area, would degrade the performance in the other area. For example, if you reduce the image noise, if you want to reduce the image noise, you may have to increase the fluoro dose, and this will in turn increase or by integrating the multiple fluoroscopic frames. And an increase in the fluoro dose will increase the exposure to the patient, indirectly increasing the exposure to the doctor or the operator. Now, you need to know some dose vocabulary which is commonly mentioned in most of the textbooks as well as in most of the lectures. So, what is the fluoro time? It's simply the time during a procedure that the fluoroscopy is used. So, you may have heard many operators saying that they have done an angioplasty in a record fluoro time of say 2 minutes or 3 minutes. But the important part is that it is of no use because it does not include the acquisition imaging or cine imaging, and it almost always underestimates the total radiation dose received. So if you look at this scatter plot, you will see that the fluoroscopy time has no relation to the clinical dose that the patient receives or the operator receives. Then the concept of karma, which is basically kinetic energy released in matter. It's a measure of the energy delivered. So air karma is measured in air, and the peak skin dose is the maximum dose received at the local area of the patient's skin. So if you look at the right hand side image, here you will see that this is the X-ray tube which emits the X-rays, and you have a particular reference point which is referred to as the interventional reference point where you measure the air karma, and here you have the table on which the patient is, and this is the organ, and above you have the image intensifier or image receptor. So total air karma at the interventional reference point, also called the cumulative dose, is measured in the IRP, and we'll have a look at where the IRP is generally measured. It's a fixed point in the gantry, and this is the point where you measure the air karma and which is specifically associated with the deterministic skin effects. Okay. This is the isocenter, and this is the focal spot from which the X-ray is emitted, and then you have at 15 centimeters from the isocenter, you have the interventional reference point, which is a fixed point to the system gantry. The air karma product, now also referred to as KAP or DAP. So DAP is dose into the area of the irradiated field. That is the total energy delivered to the patient, and this is a good indicator of the stochastic risk, and it's a poor descriptor of the skin dose. We'll come to what is deterministic and stochastic effect in the next few slides. So this is the typical diagram of as to how the patient lies on the CATHLAB table. You have the C-arm, you have the X-ray tube below, and you have the image intensifier, also known as the II above. And from here, the X-ray is delivered and it reaches the patient, and at 15 centimeters from the the entrance point, you have this interventional reference point. Now, what are the radiation risks? Now, the radiation source for the patient is it comes from the X-ray tube. But for the medical personnel, including the anesthetist and the staff nurses and the operator, the radiation dose comes from the patient. So if you want to lower your radiation exposure, you need to lower the dose to the patient first. Now, what is stochastic effect? So this is the non-threshold biologic effect of radiation that occurs by chance, whose probability is proportional to the dose, its severity is independent of the dose. And that is the radiation-induced genetic damage and mutation. It is proportional to the cumulative radiation dose over time. This has a long latency period. There is no threshold dose below which genetic damage will not occur. These effects are typically cancers of the skin, thyroid gland, nervous system, and the GI tract, and there is a linear non-threshold dose model. Whereas deterministic effect is directly proportional to the amount of radiation which you receive. There is a dose threshold, and it is basically because of radiation-induced cell death. And the most important is a skin burn, which is a well-documented radiation-induced effect in the CATHLAB. Lens opacities and cataract, affected fertility, and reduced count in the WBCs are all deterministic effects. Now, interventional radiologists, they have the highest radiation dose, followed by interventional cardiologists, whereas EPs have the least exposure. And because interventional radiology have longer fluoro times and utilize high dose per frame rate and more use of DSA, especially when working with pelvic or endovascular systems. And if the anesthesia guy is standing on the left side of the patient, they tend to have more scatter radiation as compared to when the to the operator who stands on the right side of the patient. And also because the anesthesiologists tend to have ineffective shading, because they tend to have more direct patient contact during the procedure. This is an estimate of the threshold for the tissue effects and the various tissues, right from the low sensitive to the high sensitive. Probably the bones are the highest, they tolerate radiation to the highest level, whereas all the other organs are low to medium tolerability to radiation. And as I said, cardiology, in the cardiology procedures, structural and valvular cardiac procedures have the highest exposure, followed by peripheral vascular procedures. And out of the structural ones, TAVI, mitral clip and LA closures tend to have higher exposure. And that is probably because the operator is still getting experience with these procedures, and as time goes, then the exposure may reduce. Now, if you have a look on the right side, for a diagnostic angiogram, the total exposure is around 7.6 millisievert. Now, the absorbed or the effective dose is always expressed as sieverts, whereas the absorbed dose is measured in gray. So, a diagnostic angiogram will have an effective dose of 7.6 plus minus 6 millisieverts. A diagnostic angiogram plus a PCI would have 22.4 plus minus 16.5 millisieverts. PCI for CTO would be much higher. Again, a TAVI having a moderate to high range of exposure. So comes the concept of an effective dose. So what dose is absorbed by the patient is referred to as an absorbed dose, but that is of no value. You need to know the effective dose, because that is the radiation health effects for a population. So how do you measure the effective dose? So you can have something with an equivalent dose and an effective dose. So effective dose is basically the tissue weighing factor multiplied by the equivalent dose, whereas the equivalent dose in turn is the radiation weighing factor multiplied by the absorbed dose. So if you have the whole body exposed to 1 milligray of gamma radiation, then the effective dose would be 1 millisievert. Whereas if only the head is exposed to 1 milligray of gamma radiation, then the total effective dose would be 0.07 millisievert. Now the radiation risk to the patient. So this is the most important radiation risk, and as I always say, that we tend to ignore this skin injury very commonly. So any patient who has had a very prolonged procedure with more than say 5 grays has to be examined thoroughly for skin lesions, because the skin at the site where the fluoroscopy beam, especially the back, enters the patient receives the largest radiation dose and is therefore at greatest risk, and this may manifest a few weeks after radiation and may take almost an year to completely mature. It is the most common tissue reaction occurring after fluoroscopic guided cardiac procedures. Hair loss is very common with neurointerventions. Skin will require about 2 months to recover from a dose high enough to cause any visible injury, and 1 month may be required for the affected cells to die, and a second month for tissue regeneration. And higher doses for subcutaneous microvascular is damaged and regeneration is incomplete, and previous irradiated skin reacts abnormally if doses are about 3 to 5 gray. This is a very common chart mentioned in most textbooks, where you have a relation between the total skin dose and the various times at which you have these skin manifestations. So generally speaking, anything above a 10 gray can cause permanent damage and atrophy of the skin, and may also require surgery if it is more than 15 gray. Who are the high risk patients? The obese patient, those who undergo complex PCI or CTO, repeat procedures within 30 to 60 days, other radiation related procedures, and a 15 gray is something very, very high, and you can have a sentinel event in this case. And every patient should be, his back should be examined, because that is the area where you have maximum exposure. And if you feel skin changes, then always tend to increase the time between the stages. And if there is no entrance beam port overlap, each session should be considered separately. And sometimes you can have unknown etiology skin reactions, and skin biopsies are likely to be performed in the absence of a radiation history. And these biopsies would in turn result in secondary infections. Now, radiation risk to the operator. Now, what has been seen is that we tend to protect ourselves with the lead apparels, and because of the heavy lead apparels, which can weigh something from 5 to 7 kgs, although the lightweight lead apparels weigh much less, but still there is a higher incidence of spine problems in these doctors or cardiologists. And as you go from depending upon the years of fellowship, a guy who's been into interventional cardiology for more than 20 years, we can see that there's a very high incidence of cervical and lumbar spine problems. And again, this is the problems right from the lumbar spine to the hip, knee or ankle and the cervical spine as the years of the interventional cardiology grow. Then the relation of illness with exposure to the cath lab, skin lesions, orthopedic illnesses, cataract, hypertension, hypercholesterolemia and cancer. All these are known to have increased with the exposure to the cath lab. Cataracts. Now, interventional cardiologists have as much as 3 times increased rate of posterior subcapsular lens opacities, and 50% of the cardiologists may have, precursors of cataract with more than 15 years of exposure. It has been seen that left-sided brain tumors are very common because the left side is the most commonly exposed to the patient as compared to the right side, and the new age research also shows that there is a high carotid intermedial thickness and leukocyte telomere length, and which are markers for atherosclerosis and biological aging in patients who are exposed to low dose ionizing radiation. Also, it's very important to wear the thyroid shield because we have seen doctors being careless not wearing the thyroid shield, but thyroid is something which is very sensitive to radiation, and even after 20 years you can have thyroid tumors or thyroid cancers, both malignant as well as benign. So the average background radiation in India is 0.8 millisieverts per year, and the epidemiological evaluation of this risk is actually not known. So there is something known as a linear non-threshold level. So the nominal risk coefficient for lifetime fatal cancer induction is 5% per sievert of effective dose. The risk is substantially higher in young children and declines over life. By way of comparison, a 60-year-old cancer-free male with no special risk factors has a 16% probability of being diagnosed with cancer in the next 10 years. And multiple studies have shown that there is no confirmed evidence of increased cancer mortality, and most of the laboratory staff generally receive less than 1 millisievert per year. And this is the diagram. Now, this is the right-hand side diagram shows the exposure of very high exposure of say more than 100 millisieverts, probably which may increase the risk. But at the doses at which we are exposed, the risk of cancer remains practically and theoretically very low. Now, how do you protect yourself from radiation? This was about the physics and the radiation risks. Now, how do we protect ourselves from radiation? So, see, 1 cine is equal to 10 fluoro, and 1 DSA is equal to 10 cine is equal to 100 fluoro. So the simple idea is that try to use fluoroscopy as and when possible. Try to decrease the amount of cine and try to avoid DSAs. So there is a concept of ALARA, which is basically as low as reasonably achievable. So less exposure, less dose. Now fluoroscopy only when you look at the monitor. Review the last image hold for study or consultation. Avoid using DSA. Try to use a fluoro looping, which is very commonly used by experienced peripheral operators. Use balloon and wire markers and only use fluoroscopy after that. Less number of views, cine runs and retakes. Again, distance. Now try to keep yourselves away from the radiation. Operators should avoid a place next to the tube. Don't lean over the patient. Stand upright. Keep your hands out of the radiation field, which is very important, especially when you're taking a fluoroscopic femoral puncture. Try to avoid getting the hands in the direction of the X-ray beam. Put the detector as close to the patient. Now, I'll show you in the next slide. Although radial, for all practical reasons, has replaced PCI through the femoral route, but studies have shown that radial access tends to have a small but yet significant increase in the radiation dose exposure. Now, this is the patient position. Now, the II, which is the image intensifier, should be very, very close to the patient as possible, and the image detector should be placed the image detector should be placed close to the patient to avoid the geometric blurring, whereas the X-ray tube should be away from the patient to lower the skin dose and keep the patient's extremities out of the beam. So the right way of doing it is the panel A, where you can see that the amount of the effective dose is 1 dose unit, because the image intensifier is very close, almost touching the patient, and the X-ray tube is far away. So the distance from the patient, and then keep the table as high as possible, which also reduces the or increases the distance from the X-ray tube. So if a distance from the X-ray tube is 80 centimeters and the patient is very close to the image intensifier, the amount of exposure is very less. The tube angulation. Now we'll come to this. Now try to avoid extreme angulations. So anything like a lateral or an iliocranial will have maximum exposure to the patient. Okay, so don't go for very steep angles, and even if you need to do it, try to change the beam angle every 30 minutes. Don't try to work in a same or extreme RAO or LAO. Try to make it more shallow, RAO or LAO. The use of steep angulation should be minimized and used only if necessary, and every 3 centimeter additional tissue doubles the dose to the patient. Higher head exposure occurs during the oblique angle projections when the X-ray tube is tilted towards the operator or staff. Radiation exposure decreases when the tube is tilted away. If given the option, stay on the second side. And scatter is still directed towards the waist regardless of the tube tilt. So by doing or avoiding these extreme angulations, you may protect only the head and the eye, but waist exposure still remains. Magnification. Now magnification will increase the patient dose, and there is something known as a live zoom even available in our labs, which will prevent further radiation exposure. You can also use retrospectively stored fluoro, and this mode allows the last 10 to 30 seconds of fluoro to be stored as if it was a cine run. And again, a very important feature, especially when you're taking a clear stent or a stent boost, or especially when you're taking a digital subtraction angiography, try to use collimation. This is an adjustable lead shutter which is located at the exit of the X-ray source that can be closed down to limit the irradiated area, which also decreases the scattered radiation. And this appropriate collimation should be used for the imaging. This lowers both the patient's dose and the staff's. Modern systems are also equipped with virtual collimation. Then the concept of an automatic dose rate control, by which the total dose that you received is actually controlled by the program receptor irrespective of the patient size, and it can control the tube voltage, the tube current, the pulse width, and the beam filtration. Now this is the typical the projection which I was talking about. So most radiation exposure is for patients in LAO and RAO caudal. For operators, it is for lateral and iliocranial. So LAO caudal and RAO caudal is maximum exposure for the patient and for the operators. So you need to chop and change. You cannot try to keep. If you try to have more exposure to the patient, then the scatter radiation will increase, and vice versa. If you use more exposure to the operator, the direct radiation will also increase. Now this is how you perform an angiogram. You can see that it's being done under a very low fluoro low fluoro settings. It's 7.5 frames. On the left hand side, you can see that the air karma, the total air karma, and the dose area product is written, and the collimation is done. Okay. So here you can see that we are doing the work under fluoro. Try to go a little LAO. Now some of the operators do it under an EP, but it's preferable to do LAO to engage your catheters.
Sir.
Then the RAO caudal view. Now this provides more radiation to the operator. Okay, but again the frames are very low, so if you need to avoid radiation exposure, try to reduce the amount of frames. So the average frames per second by which the operators operate is around 7.5. You can bring it down to even 3.75 in some cases. Again, the LAO caudal view. Again, you can see that as you do the fluoro, you can see a gradual rise in the product, dose area product, and this is the PO cranial and the RAO cranial views. So acquisition protocol. Now the most important thing is the system with which you work. You need to be familiar with it. You also need to know how you can reduce the amount of radiation exposure to the particular setting. So you need to be, the same system may be different in different labs. So you need to get properly adjusted to your system that you use. These are the various, properly set programs. Try to set the dose level, the frame rate. Okay, try to use 7.5 frames. Try to use more of fluorostore. Okay, and try to avoid DSA and CNS. This shows you the whole of the reading right from the fluoro, whether it's normal, low, high, and the frames per second also. Now we come to shielding. Now shielding is critical for the protection of the medical personnel. So right from a lead apron, thyroid shield and eyewear, a ceiling mounted lead shield, table side shields, protective garments which stop approximately 95% of the scatter radiation, and check your aprons for cracks regularly. So if you use all the protective equipment, the protection from shielding can be more than 95%, close to around 98 to 99%. Now, a lead cap, there are controversies regarding the use of a lead cap. Some of the studies have shown that it has been able to reduce the radiation dose only by 3.3%. What would be more useful is to wear a hood, which may actually cover more area and prevent further exposure. Again, lead gloves have not shown to be useful, because if you wear a lead gloves and try to expose yourself, your hands to the X-ray beam, what would happen is that the X-ray machine would detect it as an inability to see the the object in question, and would try to increase the dose, so ultimately resulting in increased scatter radiation and increased dose to the patient. So the best way is to protect the hands is to keep them away from the direct radiation beam. Leaded glasses, especially the ones which have a wide range of coverage, they can reduce the exposure to as much as 97%. And a thyroid shield should always be worn, because as I said, the effects on the thyroid gland can be seen as late as 20 years after exposure. The lead apron, nowadays we have the lightweight bismuth lead apron, which can be worn quite easily and plays a very important role. Try to wear the double lead apron with a skirt and a vest rather than using a single lead apron, and try to use the lightweight ones to avoid back problems. Take proper care of your apron. This is what we have seen in most of the labs, but it's important to take care of your apron and get it regularly checked. Then ceiling suspended shields made of transparent leaded plastic. Now these are available in most of the labs but are not used, which can decrease the operator radiation by more than 70%. But you need to reposition it. A shield which is far away from the doctor would not help. Try to bring the shield between the patient and you, so that the amount of scatter radiation goes down. Then you have disposable radioabsorbent drapes, which consist of bismuth, barium or tungsten antimony, which have been shown to be effective in reducing radiation doses. Now this is the typical figure of how we should go. You have the detector close to the patient. You have a movable lead skirt. You have collimation. You have a position between the shield between the patient and the operator. You have a radiation safety cap. You have the glasses, lead skirt, vest with thyroid collar. Also a disposable shielding. Now the disposable shield is also available, but not commonly used by the operators, but you need to do it to reduce the radiation exposure significantly. Then you have something which is a zero gravity system. Now this is not available in our lab, but then it uses a ceiling which suspended gantry system to support a walk-in lead-lined suit that eliminates the weight of the lead aprons being placed on the body of the interventionalist. But this is it has not been shown to be very popular, because it becomes uncomfortable for the operator to move around. Then you have the rampart system. Now this is the concept of going lead free. You also have the egg nest, where these shields will permit the operator from wearing any equipment. They don't have to wear anything, and I'll just show you how this works. So this is the operators performing the angiogram without even requiring the personal lead apron. So this is totally safe. Although the exposure to the patient would be there, the operators have no exposure at all. So this is a concept which has come into vogue, and nowadays more and more of the labs, especially the CTO operators, tend to adopt this rampart system. Then you have the robotic system. Core path is not very popular, but can be done for very simple cases where the interventional cardiologist can sit outside and control and do the procedure with the core path robo. Now these are the staff exposure limits for the whole body. Effective dose of 20 millisievert per year, averaged over 5 consecutive years. Eyes 150 millisievert per year. The latest recommendation is 20 millisieverts. Extremities 500 millisievert per year. Skin 500 millisievert per year. And public 100 millirem, which is 1 millisievert per year. This is something real-time skin dose mapping which is done to understand the effects on the skin. Then always wear a personal dosimeter. Now this is what a dosimeter looks like, where you need to wear this dosimeter below inside the lead apron, which has it has a badge number, the hospital, as well as your name and the time of monitoring, right, from say October or December 2023 or 24. So the monitoring period should be ideally 1 month, that should not exceed 3 months. So this badge is a radiation monitoring period of 3 months, and never use it in another hospital and do not take it home. You may also use a ring badge if you need to use a hand in the field. This is a real-time personal dosimetry which will give you a real-time monitoring in the cath lab, which enables staff to see their level of exposure at any time and can alert them when their levels are spiking. Can still be used when not used as a daily practice. These are the various, it's a journal, you need to go through it, which will give you all the, the newer available ways to protect yourself from radiation, all the equipments as well as the devices available. One statement regarding the pregnancy. Now, organ malformation can occur at the threshold dose of 250 milligray. Intrauterine growth retardation at 200 milligray and delayed mental development with 100 milligray. And fetal dose in this range seldom happens unless the uterus is heavily irradiated. There is no threshold for childhood cancers, no difference in fetal outcomes in women who were exposed to a cumulative radiation dose of less than 50 milligray during pregnancy, and lower risk exposure when exposure occurs after 20 weeks, lower exposure by avoiding extremely cranial angulations and using a radial approach. So for pregnant women, they allowed occupational doses 0.5 millisievert per month and total of 5 millisievert during the span of the pregnancy. And they should wear the inner badge at the waist level to provide a better estimate of potential fetal dose. So I'll come to my final slide. The take-home message is that patients should be monitored for skin reactions if more than 5 gray radiation is used. For stage procedure, review old fluorodose and examine the skin changes. Keep it as close to the patient as possible. Low frame rate and low dose fluoro. Maintain distance. Avoid extreme angulations. Avoid the lateral and iliocranial views if possible. Minimize DSA and cine. X-ray is a weak carcinogen but does not mean that this sentence, do not let this sentence fool you. You have to be very careful. With every incremental dose, there is a low but definitive increase in cancer risk, and use all protective equipment and maintain properly to avoid cracks. Thank you.